I'm Sheldon Martin. I'm the orthopedic surgeon for the Arizona Rattlers, as well as some other teams here in Phoenix. So I take care of a lot of athletes at all levels and all ages, from 9 to 90, from the professional level down to the high school level, as well as recreational athletes. So I have a lot of experience with athletes and ACL injuries, and today what we'd like to focus on is what do we currently know in 2017 about ACL injuries. And I want to try to make this impactful for you guys. So basically we'll keep it pretty superficial in terms of how prevalent are these injuries. You know, why do we even care about it? Why are we here today? We'll talk a little bit about the ACL, that ligament, and what it does in the knee and how you injure it. We'll talk about some predisposing factors that can cause you to injure it. If you do injure it, what you can expect to see when you go to the orthopedic surgeon like myself or somebody else to take care of you. How do we take care of an injury? And then we'll talk about the recovery period. So, you know, why are we here today? Why is this such a big deal? So watch this video.
Best season of my NFL career. Halfway through the season, we're playing in New Orleans. Make one simple move, break to the right, and my knee goes out. Drew Brees is taking the Saints down the field. I got to figure out a way to get back in this game. But at this time, our trainers, they knew that it was ACL. It was one of the worst experiences ever. You know, going from, playing extremely well, being at the highest level, and, to be humbled just like that in one single play. The knee has recovered well, I'm strong, I'm fast. First day back doing the linebacker drills, and feel the same pain in my knee that I felt in New Orleans. And instantly I knew. I rehabbed that second knee injury. Come back, 2 games into the season. They're making a drive, I go to make a tackle. One of our linemen doing his job ends up leg whooping me. It's the 3rd ACL. It's torn again. 3 ACL tears in 3 years. I didn't think that I would be able to continue to play. In this game, guys don't get that opportunity.
I had to be strong, and if he needed to cry on my shoulder, then let him cry, let him get it out. And once he got it out, there was no stopping him.
God strategically set all of that up for me to win the Walter Payton Man of the Year award, for me to be a light to them, for me to display everything that had gone on in my life for someone else to see. And whether it motivates one person or 1,000 people, it's all been worth it, and I wouldn't change a single thing that has happened in my life. God knew that by this happening to me, I could motivate other people to continue to want to fight and want to push through the injuries or whatever they may face in life, because it's already been written. You just have to follow the process, be willing to stick it out. You have to be obedient, and you have to listen to God.
He is one of only 2 players to ever return in the NFL after 3 ACL reconstruction surgeries on the same knee. So clearly it had a huge impact on him, but unfortunately it doesn't just impact a single person, right? We estimate that there are 250,000 ACL injuries across the United States every year. Most of these are treated with surgery. So it's an expensive surgery, as you can see, $35,000 on average for a surgical episode. It's 6 to 12 months to get back to playing a sport, and that's not 100% return. So they're re-injuries. Up to 12% of these 250,000 injuries can re-injure that ACL graft that's been repaired surgically, or the other knee, the healthy knee. So it's a huge impact. So the anterior cruciate ligament, what does it do? So it's a ligament inside the knee, and if you watch this cartoon here of this skeleton, and that right knee we're going to focus on. So as a person is walking, you see that there's rotational force around the femur bone, the bone above the knee, and the tibia bone below the knee. They're not just moving front and back, but they're also rotating. And so if we zoom in on the knee here and we look at all the structures of the knee, here on the outside of the knee, that lateral collateral ligament there in blue, The green ligament there in the back of the knee, that's called the posterior cruciate ligament, posterior meaning back of the knee. Here's the other collateral ligament, the medial collateral ligament on the inside of the knee. That one's commonly sprained, probably more often than the ACL is injured. In pink and green there, you can see the two meniscus. Those are cartilage shock absorbers that sit in the knee and provide cushion between the femur and the tibia bone. So now if you remove the femur bone, you can see in red there that anterior cruciate ligament is traveling from the femur down to the tibia, and you remove that PCL ligament so you can kind of focus on the ACL. You can see how it kind of spirals and twists down from the femur to the tibia, and that's how it provides control to those rotational forces in the leg, and also the anterior, or the forces of the tibia moving the tibia forward when you're walking. So basically the ACL, really the main function is to provide rotational control in the knee. So when you're cutting and twisting and pivoting on the field, it's that ACL that's keeping your knee stabilized. So how do you injure it? All right, great question, right? So if you look at this cartoon and we zoom in on the knee, you watch the knee flex and extend. For the most part, it's kind of a hinge type motion, right? But if you look more specifically, as you watch the knee bend, there are subtle forces, rotational forces, there's subtle anterior and posterior or front and back movement, which we call gliding. So it's not just as simple as hinge motion, and it's those subtle motions that the ACL helps control or helps stabilize. So as you're running and these rotational forces on the femur and the tibia are occurring, so as this guy plants on his right leg right there, you see the knee is partially bent. The foot is going to be planted on the ground or on the grass or the turf. There's going to be a rotational force on the femur that causes that ligament to tear. Okay, and so when the force is greater than the strength of that ligament, that's when you tear it. So let's watch it in live format here. This is the 2012 NBA playoffs. So right there, Derrick Rose in white just tore his ACL.
He was flying and he came down wrong on the left foot. Now whether it was an ankle or a knee, I do not know. There's Coach Collins out there and all those teammates running in this. With the injury, we just talked about the 26 games he has missed. With an assortment of injuries and now holding a knee late in a game that is already decided for all intents and purposes.
I'm sure everyone around the country is going to say, why was he in the game?
So he comes down on the left leg. Keep an eye on the left leg. There. Yep. When he planted it, that's when whatever.
So this next segment right here, you're going to watch him plant on his left. Now he's going to land on his left. Right there is where he tore it.
On that left leg.
There was some give on that knee, and you can see it.
He lands right there. See, the knee buckles in. It's partially flexed. There's what we call a valgus motion where the knee kind of collapses in. The foot was planted and it rotates, and that's how it tears. And so probably 80% of all tears are what we call non-contact. So he didn't get hit by anyone, right? It was just the way his knee was positioned in space when his foot was hitting the ground. And that's probably the way 80% of people tear it. Of course, then there are contact injuries. If you get tackled or collide with someone, you can tear it that way as well. So why does it tear? There are probably three main factors, right? The type of sport you're playing, and so sports that involve cutting, twisting, pivoting. There are gender-specific issues that we'll go into in a second, and then the types of shoes and the type of field that you're playing on. So high-risk sports, anything that involves cutting, twisting, pivoting. So soccer, football, basketball, probably the top three, but we also see them in volleyball, gymnastics, snow sports, and water sports. So young females are currently the fastest growing population for ACL tears. So females are 10 times more likely to tear their ACL than males are. We still see more males that tear it because there are absolute numbers of more male athletes than there are females, but that's changing quickly. And so ages 12 to 25, those are the highest at risk, right? So it's you guys in here in the room today. So, we won't go into this in great detail, but why do we believe that females are at higher risk? There's certain anatomic factors about your body. If you look at the knee, this intercondylar notch, what the heck is that, right? Well, it's this groove. If you look at that picture, the groove in the femur bone in the middle of the knee where the ACL travels, it's like a tunnel for the ACL ligament. It's more narrow in females. And so sometimes when I get in on these surgeries, they have a really narrow notch, and you can see that the ligament was kind of rubbing against the side of the wall. So is that causing it? We don't know, maybe. Increased Q angle, what's that? Well, if you draw a line up from your hip down to your knee, the bigger that Q angle is, the more valgus moment is on the knee, and the more that knee wants to buckle in. What about joint laxity? Well, females have higher estrogen levels. Estrogen causes laxity of ligaments. What about muscle balance? Hamstring weakness. If your hamstrings are tight or they're not firing appropriately or they're weak, that's going to predispose you to tearing your ACL. And that's why we're here today, to show you ways of correcting that and preventing that. Tori's going to walk you through that. Proprioception or muscular control. What's proprioception? So that's your ability to know where your body is in space. So if I close my eyes and I reach my hand out, I know where my hand is, right? Your brain has a sense of where you are in space. Well, the same applies for your feet when you're running. You have this proprioceptive ability to know where the ground is without looking at it. And so we believe that with non-contact injuries, if your foot hits the ground and you don't have good proprioception, maybe that's why you tear it, because you didn't expect to hit the ground and you hit it. What about the shoe surface interface? So the cleat design matters, right? So that picture there with these really long cleats around the outside of the shoe and then these shorter kind of spiked cleats in the middle, that's a risk. That's kind of an unstable platform, and so that's a higher risk for an ACL injury wearing those types of cleats. Turf has also been shown to be 1.3 times higher risk for tearing your ACL than natural grass, because the grass can give way, whereas the turf doesn't. You plant your foot, you get hit, your foot stays planted, and the stress goes through your knee and tears your ACL. So if you do injure it and you go to see your doctor, you may see the doctor do some of these tests. It's a way of examining the knee to feel the integrity of that ACL. So this side is normal.
We feel for a solid endpoint, and you can see that there's not very much motion as we're looking at the joint line directly right here where my thumb is.
So that's a normal, stable knee. Now he's going to go to her other side that has an ACL tear on it.
We're going to demonstrate the injured knee where she's torn this anterior cruciate ligament. So same thing when we do the Lockman's exam. We'll place the knee up to 90 degrees. And she's relaxing very well. And you can see as we move.
See how much movement there is on that knee? So he's moving that tibia front. Because the ACL is torn, it can't restrain that motion.
The other thing I want to show is what's called a pivot shift maneuver, where we let the leg hang.
And so you'll see when you're watching pro sports or you're watching the NFL and the docs run out in the field and you see them examining the knee, it's typically what you're seeing them do. They're doing that Lockman maneuver. So that's normal motion in a knee. And the other side, you'll see the ACL deficient knee. So watch this knee. See that? Kind of. Okay. So right now it's kind of like dislocated, and when it pops, it's kind of popping back into joint. So what does a normal ACL look like? So this is arthroscopic video from this is a normal ACL. See it coming down from that intercondylar notch. The femur is above, and it's coming down to the tibia. So that's all normal. Now you're going to see what an abnormal one looks like, torn. So this is a 39-year-old retired NFL running back, and you see that ligament is just shredded, right? It looks like a mop. It's totally torn. So here we're getting rid of all that tissue to prepare for the ACL graft that we're going to put in there. And this particular patient got his hamstring tendon So we're just shaving away the torn fibers to make room for the graft. We look at all the other structures in the knee as well. So this is on the inside, the medial side of the knee. That's the meniscus that I'm probing with that metal probe, looking for tears. Here's on the lateral side, he's got a little tear back there. We call that a radial tear. And we're just kind of going to clean that up. That doesn't need to be repaired. It's a small tear. So you just kind of contour it back to healthy tissue. I'm just probing to make sure that we've gotten all of the tear. This cartilage up on the top of the femur there above looks normal. The cartilage on the tibia looks normal. Just being thorough to make sure we've gotten all of that tear. And then we're going to move to the underneath the kneecap. You see the kneecap above, that looks nice and normal. That's normal cartilage. And then the femur bone below it is normal. Now we're going to head back into that notch and prepare to do the major portion of the surgery now. So we're going to ream tunnels, create tunnels to get this graft in place. First thing we do is create a little bit of space here so that the notch is a little bit narrow. We make it a little bit wider so there's plenty of room for the graft. Here we just kind of clean up any remaining fibers that are kind of hanging out there. You can see that posterior cruciate ligament, the one in the back, going down the back there. That's a nice normal ligament. That looks great. So now we place a guide wire, and we're going to use that guide wire to pass basically a reamer, which is a cannulated drill, to create that tunnel. And this tunnel is where we're going to pass the graft through, okay? So there's the tunnel in the tibia. And we're going to do the same thing up on the femur. What's wrong? You guys don't like blood? So now that's a guide wire, right? So now we're going to pass this graft. This is his hamstring tendon coming up. There it goes. Right up into the femur. Right? And then we fix it on the femur side, and we fix it on the tibia side, and stretch it so it's real nice and tight. So that's what those sutures there are doing. They're tensioning it. So now the graft's in place. It's fixed. And you like to see the bleeding, right? Because that's what's going to cause healing, right? So we're just kind of cleaning it out so you can get a nice view of that new ACL graft in there. And there it is. That's his new graft. He's been doing great. So that was an ACL reconstruction surgery. What's the recovery period? Well, we get, what's that? Yeah, to return to sport, it's 6 to 12 months. And so that recovery period goes in phases, right? The first phase, the first 6 weeks, we get you going in physical therapy right away, a day or two after surgery. Therapists start working with you, get your knee moving, work on the swelling in the knee, work on the quadricep, because that thing's going to shut down. We get your gait going, get you walking, off crutches if you're on crutches. Typically you don't need them unless we did some repairs on the meniscus or the cartilage. Many times we use a brace right after surgery for the first week or two, get you out of the brace. By 3 months after surgery, we start running. At 4 months, you start higher level activities, cutting, twisting, pivoting, jumping. All those things are going to get you ready to go back to your sport. And so again, 6 to 12 months, so it's a huge investment of time and energy of going to the physical therapist a couple times a week for 6 months. And for many people, it's closer to that 12 months before they're back, 100% playing again. We're doing more research on whether braces are beneficial when you return to sport. Many of us use braces right after surgery just for a couple weeks, but then using a brace once you go back to your sport, do you use it? Do you not use it? How long do you use it? We really don't know the answer to those questions. Basically it's a 70 to 90% return to sport. So it's not 100% though, right? So not everybody that has an ACL tear is going to get back to playing their same sport. And then again, a couple of points about the braces, because I get asked this a lot in the office. Do I need a brace? Because those of you that tear your ACL, you see your friends wearing a brace, and again, we don't really know. We're still doing research on that. So in summary, this is an incredibly common injury. Okay, 250,000 ACL injuries a year. Young females, aged 12 to 25, are the most common right now. Still unclear as to the value of bracing. Treatment is usually surgical for the most part. We fix these with surgery. It's a long recovery period, and it's a high rate of return to sport afterward. But not 100%. So I want to leave you with this video right here.
You got it, baby. Let's go.
Start fast. 60 minutes, baby. Start fast. Every play, all day, baby. Let's go. Win on 3. 1, 2, 3. Win.
It's new territory for the Cardinals as they start the second half of the 2014 season, looking to go 8-1.
All right, guys. Good to meet you guys. Nice to meet you. All right. Let's go to work. Here we go. Come on 1. 3 down. Mike's 5-2. Set go. Mike's 5-2. Righty, righty. Let go.
Carson put it right on him. Great catch by Michael.
Play fake, back to throw. Palmer hit, drilled, sacked.
You listen to them talking, jabbing. Come on now. In our field. In the end zone, let's go get some water. Let's go.
Palmer takes, pitch to Ellington, running left, cuts right, and will walk into the end zone for the touchdown.
Great job. Great job. Let's go.
Carson Palmer is hurt.
Oh, boy.
Looked like a non-contact injury, and he's writhing in pain.
My foot hit the grass, and the grass gave, and it just was a freak thing that, unfortunately, that the ACL gave way. Felt it right away, knew right away that this year was over for me.
We're human. Long before Carson's our quarterback, he's our friend. You know his kids, you know his wife, those type of things you think about.
I'm not gonna lie, I cried like a baby last night, and I'm not an emotional guy. It's been such a fun year. I'm having more fun than I've ever had in my entire career. I'm on the best team I've ever been on. There's something special about this group, and that's, like I said before, that's what I'm gonna miss most is this opportunity. It does not come along often. I'm gonna play football again.
So again, you see the impact on one player. He's a professional football player, grown man, crying over this injury because he knows what it involves, the next year out of his life. So wouldn't it be great if we could prevent these injuries? And I'm going to leave you with that thought because that's what Tori's going to come talk to you about.
Once again, I'm Tori Foster with Spooner PT. We have 16 clinics throughout the valley, none in Yuma yet, never know down the road. But we're at Shea and the 101. I want to give you a little personal history of myself. I was a 4-sport athlete in high school and a 2-sport athlete in college. And I tore an ACL my junior season in college. And when I did that, I didn't know what I didn't know. You know, I thought at the time I was relatively fast, relatively strong, and I just wanted to get back out in the field. A few years later, I tore up my other one. Same question, why is this happening to me? And it really got me going and thinking about how I could help other people, not only as a physical therapist, but also a physical therapist who specializes in knee rehab and ACL prevention and rehabilitation. So, you know, looking at that, it really made me analyze my training. What was I doing? Well, the Olympic lifts, you know, a lot of those football lifts we do, I wasn't working the side-to-side motion. I wasn't working in the rotational plane. So looking at that, I like to describe, I think Usain Bolt, pretty fast guy. Why doesn't he play football? Well, one, he makes a lot of money running, right? But the other thing is we don't know how quickly he can cut in a 90-degree angle, okay? So out there when we did your exercises, we try to do different things in different motions. You could squat in 3 planes of motion. You can jump in 3 planes of motion. You can hop. You can lunge. We're going to go through a little bit of that in a moment. We want to think about, we want to accelerate, but we also have to properly decelerate that motion at the same time. We have to load to explode. So I'm going to have Dalton here. Can you jump for me real quick? Yeah, just jump, just jump. Good. Do it one more time. That was great. Can you go any higher? Probably. Great. Can anybody tell me what he did first in order to jump? What, louder? Use his arms. Exactly. It's a full body motion. What else did he do? Before he went up, he went down. You have to load to explode, okay? You have to control that landing. We also have to look at controlling mobility. So if something's tight up at the hip and or the ankle, what gets caught in the middle? The knee. We want to be able to have the mobility to control that. We also want to have what I kind of look at as kind of a train and a track phenomenon. The knee is a hinge joint. We got a lot more movement that happens down at the ankle and at the hip, okay? So if Dalton and I go over to the monorail, which is in Tempe close by here, we say we want it to go to the left, the conductor's going to kind of laugh at us and say, well, I'm going to go wherever the track takes me. Exactly. So if we move the track and we say we move that track to the left, everything's going to follow. So if we can't just control the knee, we've got to control the whole track, that whole chain of movement, okay? What does that? Well, as Dr. Martin said, quad's a big, important muscle in the front. Hamstrings are important in the back. Calf. What do we have in the back side here? Anybody know what that muscle group is? What? Glutes. Yeah, that's right, glutes. We're given big back sides not just for cushion for sitting, but for using, okay? Those are big, important muscles that come in a diagonal pattern and help control a lot of the movement in that leg, okay? So without further ado, we're going to do a couple things. So we saw Dalton jump. Let's take a look at his squat. Would you squat for me? If you need to stand up to watch, by all means. Beautiful. Again, a little deeper. Great. Looks wonderful. So if we looked at that squat, we'd say that looks like a good squat. Let's go exercise. But let's see what he does in the single leg. Can you do a one-legged squat there? Good. Do it again. Go a little deeper. Okay, everybody see that? Can you do the other leg? Good. Again. Okay. You see any maybe lack of control there? Some opportunity? Exactly. So we call that a valgus movement. That's a big movement of potential injury in the knee. So it's something we could obviously work on. Okay, that's just one example of a test. So what I want you to do is bring your knees towards your chest and back. Good. That's a squat thrust. Okay, can we do it again? Good. So next thing we're going to get into are lunges. So Dalton, could you show me a lunge, please?
You want to try
Another what?
athlete?
Well, we can. He's doing great. He knows what we're doing. Okay, let's do a front lunge. Front lunge.
I tried though.
Good. Do it again. Doing great. Now how about a side lunge? Good. How about a rotational lunge? Aim that way. Awesome. How many people here do lunges in more than one plane of motion right now? I see a hand. Good. A couple of hands. Small hand, maybe a little bit. Okay, great. He could do that, and guess what? We could see how quality is the movement. So when he comes down, is he able to get down there? Is he able to get back? We could do fast. We could also do things with dumbbells. Load it with dumbbells. Get some weight into it. See some big, strong people in here? Okay? Let's make sure that you get stronger with movement, with speed. Okay? So lunges, don't just think one plane of motion. Jumps. We did jumps out there, right? Dalton's a trooper here. Okay, so we think about jumps. Go ahead and jump up to the front. Yep, jump up and down. So one of the things that we'll do, and Dr. Martin, and I think there was a question who alluded to it, nice job, thanks, is that we want to know psychologically how the person is performing. So when we look at that, it's kind of bridging the gap for what's the next step in an exercise progression along with the rehab, is we've got to prove the level of success before we move to the next step. So looking at that, maybe we do 30 seconds onto here. Okay, maybe we do 12 inches, maybe do 18 inches for the taller athletes, depends. See how many they do, okay? What's the quality of control going up and coming down? Sideways, go up there sideways if you would please, up and down. Right leg lead, left leg lead. Now he does a great job of that, come on down and rest. If you have somebody that's gone through the rehab, you might find somebody where they're gonna jump up there and they don't wanna get that other foot on there. So if it's my left knee, you're gonna see that apprehension. Psychologically, we've got to demonstrate that ability to do that before we move on to the next step. Typically, you can go front to back a lot easier than you can the side to side and the rotational movements. So when you did the hops, were those hops harder than the jumps out there? I see some nods. Anybody else? Yeah. The hops are definitely harder. So why is that? Well, you don't have the other leg helping you, okay? So when we do that, go and go side to side hop there for me. Oh, sorry, hop one leg. I didn't correct it. One side, one hop. Okay? Now when you did that, you're going to start feeling some different muscle groups. Obviously, you're engaging your quads. Some of you might have felt your quads, especially when you're going further into the exercise. But a lot of times you're getting that, you're loading that calf muscle. You're loading that glute muscle. You're trying to get those other groups of muscles engaged because muscles are engaged a little bit more in one plane of motion than another plane of motion. Also the depth of movement, okay? So when we look at change of direction that you were doing out there, another piece of that is if I want to go there really quick, one is I probably want to get low and come here. If I don't get low enough and I stay up here and I go to change, what happens? That knee's at risk. I am not able to get to that point where I can help get my glute to help me to come back the other way, okay? So we also want to think about the depth. So we talked about ACL injuries in women, and I think basketball players are one of the higher incidences with female athletes, and Dr. Martin can correct me if I'm mistaken. But it's also not only jump, but the coming down. If they come down, those knees come in, there's a lot of risk for those tears. You saw Derrick Rose go up. He came down that left knee and went into that valgus strain, okay? Control that movement. So we talked about different things we could do. So we're going to do a triple crossover hop. So 1, 2, 3. Actually, let's do single hop. Let's do that first. Okay, just do one leg hop, right to right. Right foot to right foot. Yep. There you go, good. So this is one of the biggest validated tests that we see in the literature is a reach test and hop test. We also can do it in the sideways movement. So stand your right foot and hop right to right. Measure distance, right foot, left foot. So if you're out there and you want to test your friend, what's the difference? We want to see that probably be at least 85 to 90% of the other side. If you're feeling a 75% difference, then you're going to be at a higher risk of injury in that particular circumstance, in that side-to-side movement. Rotational hop. So you're going to face this way and then turn towards them. Boom. Rotational hop. The good news in this group is I didn't see anybody had an ACL injury. That is awesome. That's what we want to keep it. Okay? The test he just did right there, we start doing rehab with people, is one of the probably most apprehensive tests that people have because they're going into that rotational movement. That rotation, once again, is an important part of your ability to be a quality athlete. But at the same time, it also puts you at higher risk if you haven't trained properly. It is such an important part. Go ahead and do that triple crossover, the 3 hop. Another one we'll do for distance, a triple crossover hop. Perfect. And we'll do right and left leg. We'll also do, we're not going to do it here, but a 6-meter timed hop for speed. We do all these tests. We could do it for any healthy, uninjured athlete to see where he or she is, or we do different stages in the rehab cycle to make sure that we demonstrate that success at 3 months, at 4 months, at 5 months. So when that athlete goes back to Dr. Martin and says, I'm feeling great, you can feel great, but you also have to move great. And that's a big, important part of what we do. Hey, Dalton here. You've been such a great help. I got a couple gifts here for you. No, I'll bring somebody else. All right. Thanks, buddy. Appreciate your help. Applause for Dalton, everyone. A big part of what I wanted you to feel through the exercise is how any exercise can be taken through 3 planes of movement. A big piece of what I want you to understand with injury prevention is that there's great exercise. If you want a barbell squat, barbell squat. If you want a hang clean, hang clean. But you want it cross-trained to prepare your body for when you're going out in the field. Gravity is a huge assist for us. Use it to your advantage. Just how you move in that plane of motion that's going to help really guide you. Biggest thing is we want you to have fun. We want you to train. We want you to excel with your counterparts, your teammates. Because a big part of it is when you go out and you injure your knee, if you do that beginning of your junior year, you're out that entire time. It's one thing we see a professional ball player go back out there that next year, hopefully. But if 10 to 30% of people don't return, it's a big percentage. You don't want to get injured. And if you do, you want to have an excellent surgeon like Dr. Martin, and you want to go to a knowledgeable physical therapist that can help you. We want to make sure that you don't lose that junior year of high school, that sophomore year of college. So we want you out there having fun, because the thing is, the pain's going to gradually go away. But the time with your teammates, the time of those experiences, you don't get those back. Thank you, everyone, for being here, for participating. Please take this knowledge back to your teammates.